Hello and welcome everyone. My name is Dr. Medhavi Gupta. Today we'll be talking about breast cancer with brain metastasis. Having metastasis in the brain can be a matter of huge concern both for the patients as well as the medical team. After lung cancer, breast cancer is the most common cancer associated with brain mets. To discuss this topic, today I'm joined by Dr. Nancy Lin. Dr. Lin is an associate chief for the Division of Breast Oncology at Dana-Farber Cancer Institute. She's also a director for the program for patients with breast cancer brain metastasis. She has an extensive research experience on this topic and has authored a number of publications, including the recent study of tucatinib in patients with HER2-positive breast cancer. In addition, she is also an author of the up-to-date section on brain metastases in breast cancer. So let's talk about a special circumstance, I would say a rather complicated and controversial one. So patients who relapse just in CNS, they don't have evidence of disease anywhere else, and let us say they get definitive local treatment.
Right.
Do you offer systemic therapy or not? And I know this is
Right.
one area where we do not have a lot of data, but what is your experience so far?
Yeah, so this is an area where, in fact, we really have very little data. And one of the things that we not only do we not have data about the efficacy of different treatments, we have relatively limited data on the natural history of these patients. So you can imagine if you knew that everyone within 3 months was going to develop liver metastases, you'd have a very different way of approaching a patient than if you knew that half of the patients would have CNS only disease for the remainder of their life. And so I think one of the things that we don't have very well characterized at this point is really the trajectory with enough patients to really feel confident that that's truly the natural history of the disease. Having said that, practically speaking, what do I do? If somebody has ER positive, HER2 negative breast cancer, I'll offer them endocrine therapy. And again, I do that because it's quite well tolerated and the downsides are relatively small. For somebody with triple negative breast cancer, I typically will treat with, their definitive local therapy, and then I mostly just observe off of therapy, and I do reasonably frequent scans. And the reason I do that is because then the option you're thinking about is chemotherapy. And to me, it's not incredibly attractive to give chemotherapy for triple negative breast cancer in the setting of NED status because they're just not incredibly chemosensitive anyways, and then you're exposing people to toxicity. I think the tricky one is HER2 positive disease, right? And unfortunately, if you look at the adjuvant setting, none of the drugs, whether it's trastuzumab, pertuzumab in the Affinity trial, TDM1 in the Catherine trial, lapatinib in the Alto trial, none of them actually had any impact on the rate of CNS relapse in the early adjuvant setting. So it's kind of hard to get super excited about systemic therapy. I will often offer people either trastuzumab or trastuzumab pertuzumab as something that at least is sort of low toxicity, it's not going to be cytotoxic, and is relatively straightforward. But I tell people that I have no data to support that, and I kind of leave it to patients whether they feel more comfortable with observation versus like an H or an HP approach. I can't tell you that's the right thing to do. That is the practice that we've sort of taken to in our practice, because again, it's sort of trying to balance the risk-benefit profile. I do think that this is an area that's really ripe for clinical trials. And in fact, Sarah Sammons and Carrie Anders at Duke are planning a trial where patients who have a CNS lesion or lesions that are treated with SRS in the first or second line setting will actually be randomized to tucatinib or not. And so I think that will be hopefully a very important study because we don't know whether we should do anything different with their systemic therapy, if we should put people on systemic therapy. It'd be nice to get some clarity on that.